This presentation will demonstrate the use of the round zygoma implant in a Zaga 0, 1, 2, or 3 presentation. It is important to review the anatomical landmarks, and we begin with the alveolar ridge, the lateral nasal aperture, the infraorbital nerve, the infraorbital rim, and especially the lateral portion of the infraorbital limb, the frontozygomatic notch, the zygomatic buttress or the buttress of the zygoma bone, and then what I call the black dotted line, which is the area where the lateral or the anterior portion of the maxillary wall turns posteriorly, and this is the corner of the curvature of the anterior maxillary sinus wall and the lateral posterior portion of the maxillary sinus wall. To review the anatomy, once the flap is made, we look at the crest of the alveolar bone. We look at the lateral nasal aperture. We look at the infraorbital nerve. We look at the infraorbital rim, especially the lateral portion here if a quad zygoma is considered. The frontozygomatic notch, right here where the retractor sits. The base of the zygoma, the buttress, and then what I call the black dotted line, where the lateral maxillary wall curves and becomes the posterior maxillary wall. So that is right here. This is what I would call the black dotted line. And the more vertical resorption there is, the shorter this distance. In order to make the lateral sinus window, again, by identifying the black dotted line, we make the posterior portion of the lateral sinus window parallel to the black dotted line. This way we can look and see the base of the zygoma bone or the roof of the maxillary sinus. We can pick our starting point and our end point of the implant and be able to see the entire trajectory of the drills as well as the implant if the posterior wall of the lateral sinus window is parallel to the black dotted line. It keeps us a lot more oriented. So there's the black dotted line. The lateral maxillary wall becomes the posterior maxillary wall. That's our corner. The reason why this is important is when we make our window, the lateral window, we want to parallel the posterior wall of the lateral window with our black dotted line. So in order to do that, we can use burrs to make small dots, or we can use a surgical pen or pencil to actually make the posterior wall, as you can see, parallel to the black dotted line, and then maybe a couple of millimeters wide. So this is the size of our window. Now, the more inexperienced a person is, you can make it longer so you can visualize the path of the drill. But the point of the sinus window is to be able to look and see the base of the zygoma or the roof of the sinus. So we use some kind of a small burr, and as you can see, we make an opening into the sinus, and you can do it a little bit at a time, or you can just go ahead and make your little run like this, trying to keep the opening parallel and a couple of millimeters wide, as you can see. Now, if you can maintain the Schneiderian membrane, that's fine. But if you cannot maintain the Schneiderian membrane intact, that's also fine too, because it's not absolutely necessary to keep the Schneiderian intact. There's a limit on how much we can bend our head. So I have a curved instrument usually, and I try to see if I can feel the roof of the sinus. As I'm feeling, the roof is up here somewhere. So I can extend my window a little bit and make it larger in order to be able to see the sinus. So if I keep my orientation the way it is and maybe go ahead and make my window a little bigger, again, paralleling the black dotted line. And it's much better to go incrementally, go a little bit at a time. So a couple of more millimeters up. And we can check again. and to see if we can actually see the roof. And the roof is right here right now. So I'm quite comfortable. I'm about a millimeter or two. And this is the membrane that's inside the model. So obviously the Schneiderian would be a lot more delicate. So again, just to kind of have a clear path, we can go ahead and try to see if we can get the Schneiderian or a little plastic Schneiderian out of the way here without damaging things too much. So the round drill sets the trajectory. It basically makes a small indentation on the base of the zygoma, allowing the 2.9 millimeter drill to seat and not chatter. And again, as you can see, the posterior aspect of the round drill is parallel and in intimate contact with the posterior aspect of the lateral sinus window. So what I usually do is I visualize the path. So there's the frontal zygomatic notch. So if I place the tip of my round burr at the frontal zygomatic notch and I parallel the back of my sinus window with the shaft of my drill, you can see at the crest I'm at the second bicuspid first molar. So if I was to mark that again for purposes of demonstration, if my implant apex is here somewhere, my shaft or the middle portion of the implant is here somewhere, then the origin is going to be right here at the second bicuspid. And again, if I was to measure this or show myself, I would put the drill there, and that's where it is. So this is the trajectory that I would like to start. Sometimes it's difficult because the patients have small mouths. So a good way to start the osteotomy is to use the spade drill, which is a shorter drill, and then once the opening is made into the sinus, we'll go ahead and use the round drill. And the spade drill is again the same way. You direct it like this, and this is the trajectory you want. So we have our spade drill. Again, we line it up as you see here, and this is a very thin ridge. So I would like to go slightly lingual to the crest because I want to maintain that crestal bone if I can. And then we begin our osteotomy, bearing in mind the trajectory that we wanted, and we're going through the alveolar portion, following the black dotted line or the posterior aspect of the window opening. And as you can see, I'm still traveling through in the real patient, obviously that's not plastic, we will enter the sinus much faster, but in this particular case, there we go. So there is a concavity to this patient because this is almost like a Zaga 2-3 patient. So there is a concavity here. Now, if I can slightly redirect my drill and try to maintain as much of that bone, but it's nicer, but not absolutely necessary. At this point, I introduce my round drill, and I try to stay within the sinus here, keeping as much of the lateral wall as I can. You can see my shaft of my drill is butt up against the posterior wall of my sinus opening, parallel to the black dotted line, if you will. And I enter the base of the zygoma, and I'm making a small indentation so that my 2.9 millimeter drill can seat. And again, the drill is butt up against the lateral sinus wall and going up towards the frontozygomatic notch, nowhere close to the orbit, as you can see. The 2.9 millimeter drill follows the same trajectory and path established by the round burr used previously. The tip of the 2.9 millimeter drill sits in the indentation that was created at the base of the zygoma bone by the round burr, and then this way there's no chattering, and the drill is guided through the zygoma bone, exiting at the lateral cortex of the zygoma. And as you can see, the posterior aspect of the drill is parallel and in intimate contact with the posterior wall of the lateral sinus wall opening. Now I use my 2.9 millimeter drill, and I am again entering within the same. I'm looking at the shaft of my drill, making sure it is butt up against my lateral maxillary wall, and I gently go up, relatively slow RPM, until I am comfortable that I'm seated within the apex, in the round burr indentation that I had just made. And I will go ahead and now drill, making sure my drill stays against my lateral sinus opening wall, and just pump gently back and forth, until I'm feeling, and I have my osteotomy comes through the lateral cortex of the zygoma bone. It is very important to see this opening, because if we cannot see this opening, we will not be able to measure the depth of the implant to integrate. One thing that's very neat to see in this particular presentation is, if you can see, the head of the handpiece now is hitting the bone, and I cannot go any further. If I need to go further, which I don't, but if I did need to go further, I could not. That is why there actually is another 2.9 millimeter drill with a longer shaft. Okay, so if I was to demonstrate right now, taking this out, exchanging the shorter drill for a longer drill. So I got a longer drill, and if I was to re-enter the same osteotomy, as you can see, re-entering the same osteotomy, making sure I keep the same trajectory, I can now exit, and you can see I have a lot of room, right? So the point being, we don't need to go past this much, but the point being is, the more resorption we have, the more likely we need to use the longer burr as opposed to the shorter one. But the shorter one passes the patient's commissure or their lips much quicker. This one, if we're using the longer one, we have to be careful that we don't have the drill, as it's turning, burn the commissure or the lip on the opposite side. The 3.5 millimeter drill is an option for the crestal portion, enlargement of the crestal portion. The implant is a 4.3 millimeter in diameter at the platform, but it's 3.4 at the apex. So if the bone is brittle, or there's any reason to think that there might be a fracture of the crestal bone, then the 3.5 millimeter optional drill can be used. But a lot of times the 4.3 millimeter portion of the implant can actually enlarge and compress the crestal bone for intimate contact and insertion torque. Absolutely essential, it's a must that you see the tip of the osteotomy. So here's our depth gauge, and we place it inside the osteotomy. We can see again the depth gauge is absolutely butt up against the lateral maxillary wall. That's why that black dotted line is super important. We go through, and we go through the apex. Now, the apex is on a slope, so do we measure from the top of the slope, or do we measure from the bottom of the slope? It really makes no difference. This slope generally is about 2.5 millimeters long. It makes absolutely no difference if we measure from the top or we measure from the bottom. But an implant cannot be placed, or an implant cannot be predicted or pre-chosen just like an axial implant, because a slight variation in a starting point or the angle will make a difference in the length. So that's why we have to have all sizes available, and then at the time of surgery we choose it. So this idea of placing a zygoma implant in the orbit is like incomprehensible to me, because if you have to see the tip of the drill, and then you have to see the tip of the depth gauge, it is impossible to place the implant into the eye. So that's a very dogmatic thing that we have to follow. We have to know where the implant starts, we have to know where the implant ends, and be aware of the whole trajectory. And as you can see here, the depth gauge is butt up against our lateral sinus window wall, and we are in the right position. At this point, the depth gauge is placed, and we can measure the depth of the length of the implant that is needed. The apex protrudes through the lateral cortex of the zygoma and is retracted until it engages the rim of the opening, and then the number is read at the crestal portion of the depth gauge. So now we're ready for our implant. This is a demo implant, but the packaging is exactly the same as the real implant. The assistants can remove the tags, open up the box, and now sterilely they can open this implant by going ahead and removing the tab, but not touching the inside part. Okay? And what I generally do is I gently grab the plastic holder and I have the implant in my hand. Now the implant is on a fixture mount, so the fixture mount is already on the 55-degree head, and so the implant can be nicely rotated into its position. What I like to use is what is traditionally called the onion driver. It just has a big handle. I place it onto the implant, and now sometimes it rotates. The fixture mount is okay to touch, but we try not to touch the threads, obviously. And we engage the onion driver into the fixture mount and then gently disengage it, and now we are ready to place the implant. We are now ready to place the implant. So the implant is placed into the osteotomy, and if you made the 3.5 millimeter hole, it would just drop in basically. But we're following the shaft of the implant, the distal aspect of the implant, and as you can see, it is quite it is right against the lateral or the posterior wall of the lateral sinus window we made. Well, it will be soon in top, but this concavity which created that adhesions in the bone again gives us a visual that we are actually going the right trajectory towards the frontozygomatic notch and not towards the orbit, if you will. So as we're going we're turning the implant. It does take a little while, and some people prefer to use the fixture driver that fits on the handpiece at this point and use the onion hand driver at the end, but it really doesn't make a difference. And as you can see, the smooth portion starts to now just let us drop the implant, and if you watch the tip, I can change the orientation of the tip by the pressure I put onto the shaft of my onion, and that's why I like it, because it allows me to go ahead and control the tip by putting pressure on the shaft of the driver. So you can see so I can put pressure on the shaft of my driver, and as you can see, the implant is parallel to the back of the sinus osteotomy, and I'm still keeping a significant control on the direction of the implant because it has not engaged the zygoma bone yet. And once it engages the zygoma bone, I will get to feel it because I will get resistance as I'm doing right now. So I am in the zygoma bone at this point, and my pressure in trying to direct the apical portion is quite limited. And once the implant is seated, we make sure that the junction between the fixture mount and the platform of the implant is flush with the crestal bone, and the fixture mount is removed. All right, so in review, we can see that our implant is from the second bicuspid first molar, following the trajectory of the black dotted line, our sinus window being parallel to the black dotted line, back of the implant being parallel to the black dotted line. The implant is butt up against the lateral maxillary wall, so the tip will come out at the front of the zygomatic notch. Chances of it coming through the orbit is very, very limited, impossible when you have this trajectory. We have our implant flush with the alveolar ridge, and we are now ready to put on our SRA abutment if we're going to immediately convert. If immediate loading is considered, the SRA abutment is placed and torqued to 35 Newton centimeters, followed by connection of the temporary titanium cylinder and conversion of the patient's prosthesis either directly or indirectly into a fixed provisional hybrid prosthesis. So the SRA abutment is straight abutment for the zygoma implant, and we can go ahead and place it on as you would any other SRA abutment. Once we try to get this guy in the right place with our finger driver, and then we go ahead and give it a 35 Newton centimeter torque. And what's interesting is this is another confirmation when the implant does not rotate, just like in any other case, it's a confirmation that we have nice initial stability of 35-40 newtons of our zygoma implant. So now we can go ahead and put our temporary titanium cylinders on here and convert the case. I hope this was a helpful exercise. We placed our implant. We started from the second bicuspid first molar. We paralleled the black dotted line. We exited at the front of the zygomatic notch. We are butt up against the lateral maxillary wall, so we know we're away from vital structures such as the orbit and such. We have our SRA abutment in place, and we have our temporary titanium cylinder if we're going to immediate load and convert this patient. One thing I'd like to point out, the screw access hole may not be coming exactly through the central fossa of the bicuspids. So in order to do that, I would have had to move the implant platform more buccal, which would have gotten rid of the bone around the implant platform. This position of the screw access hole is absolutely no problem for the patients, and what it does, it preserves all this bone that will allow for the peri-abutment and soft tissue to settle down and seal the area from the subperiosteal region. So this is the Zaga 0123 lateral contour of the maxilla exercise using the round zygoma implant. Thank you for your attention.